Great. Hello, everybody. Hi, I'm Mary Jane Burke, the Marin County Superintendent of Schools, and I'm very happy to welcome you to this webinar this evening. Just as a reminder, this is being recorded. It will be available on the Rethinking Schools website within 24 hours. We're also providing Spanish translation, and I'm going to thank in advance Marta Baton, who will be translating for us this evening. And at this point, I'll ask Michelle Drake to provide Spanish information to those that want to go to the translation channel. So thank you, Michelle.
Thank you. Este webinar se transmite simultáneamente en español. Haga clic en el botón de interpretación del idioma que aparece en su pantalla si desea escuchar esto en español. Muchas gracias a Marta Bichon, que es nuestra intérprete esta tarde. Gracias.
Great. Thanks so much, Michelle. So to let everyone know, we have 1 hour this evening, and I want to express appreciation to all of you that have already submitted questions in advance. And what you'll find in the presentation this evening is that many of the answers to your questions have been embedded in the presentation this evening. In addition, if you have questions that you would like to have asked, please put them in the Q&A, and if possible, we'll get to some of them. But also want you to be aware that 1 week from this evening, so October 20th, we will have another session. The difference will be the session will be in all Spanish with Spanish-speaking doctors and English translation. But any questions we don't get to this evening, we'll make sure we move those forward to that presentation. I want to just take a moment to express my thanks to everyone in the Marin community who has worked so hard to ensure that we've been able to get our students back to school safely, our staff back to school safely, and our community feeling very supportive of all that's been going on, and especially express my thanks to all of our partners in the medical field, especially to Dr. Willis and Dr. Santora. So thank you very much. Tonight, you are going to have an opportunity to hear from experts who are going to provide to you information about the opportunity that's coming soon. And that will be the opportunity for our students ages 5 to 11 to get a chance to get their COVID vaccination. So the goal tonight is to attend to the science and to the data so that you will be able to have a great understanding of what the options are for our children that will potentially be coming up as early as October 30th. So let me move right to introducing to you our panel. You'll hear first from Dr. Theodore Ruel, and he is the Chief of Pediatric Infectious Disease from UCSF. Dr. Ruel has devoted his career to the study of infectious disease and the improvement of child health in limited resource settings. He completed his undergraduate study at Dartmouth College, received his medical doctorate from Yale University School of Medicine. He's a specialist in pediatric infectious disease who serves as chief of the Division of Pediatric Infectious Diseases and Global Health at UCSF School of Medicine. In addition, he serves as a specialist in the care of hospitalized children at Zuckerberg San Francisco General Hospital and Trauma Center. Next, you'll hear from Dr. Tara Greenhow, Chief of Pediatric Infectious Disease from Kaiser Permanente. Dr. Greenhow has dedicated her career to serving patients by providing preventative care, treatment, advice, and reassurance to children and their families. She completed her undergraduate study at UCLA, received her medical doctorate from University of Connecticut School of Medicine, has extensive experience at UCSF, Oakland Children's Hospital, and now at the lucky Kaiser Permanente in San Francisco, which allows for a comprehensive care structured where the overall well-being of the patient, and in this case, the children, is prioritized. And then you'll have a chance to hear from, last but never least, Dr. Matt Willis, the Marin County Public Health Officer. Dr. Willis has served as the Public Health Officer for Marin since 2013. He completed his undergraduate study at Brown University, Masters of Public Health and Internal Medicine residency from Harvard, receiving his medical doctorate from Temple University. He co-founded the RX Safe Marin Coalition to address the opioid epidemic locally and has served in the U.S. Public Health Service as Director of Primary Care on the Navajo Reservation and at the Center for Disease Control in Atlanta, where he conducted research and outbreak investigations in the US and abroad. So as I mentioned, you're having a great opportunity to hear from some amazing experts. And so we're going to go ahead and get started. And I'm going to turn over the mic to Dr. Ruel.
Great, thanks, Mary Jane. The slides pulled up here. So we thought it would be good at this point and at this kind of important juncture that Mary Jane was describing to go back and do a quick overview about mRNA vaccines, how they work, and what we know about their efficacy in children. So I'll start us off. Go to the next slide. So first, kind of due process. I want everyone to know I have no financial relationships with any pharmaceutical or vaccine manufacturing company, including any related to the content of the presentation, and I've not been involved personally with any of the vaccine trials. Next slide. So what I'm going to cover in the first portion of the talk is an overview of how vaccines work and what's special about the mRNA vaccines. I'm going to then go through some of the information that we have about the current Pfizer vaccine, what we know from the studies in adults, adolescents, and then what we hope to learn from the studies in children. And then I thought I'd end with just a couple comments on what we've learned over the course of the last surge we've experienced with the Delta variant. And then I'll hand it over after that to Dr. Greenhow, who will talk a bit more about the safety aspects. The next slide, please. So some of this will be basic for some, but I think it's good to kind of get into a common page about how vaccines work. So vaccines broadly work by stimulating an immune response to small or weakened parts of a disease-causing organism. So this is the cartoon you can see there. We often hear this word antigen. It just means basically a particle. It's usually a protein that is part of the disease-causing organism. So a little green chunk that you can see there. And we develop antibodies, which are proteins of our own body that coat and target these the enemy invaders, as it were, for clearance by our immune system. So really, almost all vaccines are really based on this same fundamental concept. Next slide, please. So there are different kinds of vaccines that have been developed over the years. Some of the first were just the inactivated, where you basically kill the organism and then inject it into people. So it can't cause disease because it's dead, but your body gets to see all of its protein or its antigen. Attenuated vaccines were kind of a next advance where they basically weaken it. So it kind of acts a little alive, not enough to ever cause disease, but enough to stimulate a good immune response. And then there have been others that are looking at subunits, mixing them with other things to amplify the immune response, and then some just against the toxin. So this is the kind of broad scope that we've had for many years. And you can see common vaccines that we all know listed in the white. Next slide, please. So what's different about mRNA vaccines? So the first thing I wanted to point out is, while these are the first and they've gotten a lot of press because of their rollout in COVID, they've actually been in development for quite a long time. Many people now are kind of battling about who gets to claim the first idea, but they began early in the 70s. The first clinical trials were done in animals a long time ago, and a trial for influenza in humans in 2015. So these have been a long time coming, and people have been working at not a COVID pace, but developing them for some time before they were pulled off to help us address this pandemic. But while there are some really interesting innovations about them, they really rely on the same exact mechanism as all these others. There's protein being generated, and our bodies are mounting an immune response. So really, at their core, they work the same as all vaccines that we know now. What's different about them is they're basically using normal human cells and normal human cell functions to make some of the protein fragments. So basically, you just get a bigger bang for a small injection where your body sees more of the protein, and the idea being that you would get a robust immune response, which is what we've seen. So next slide, please. So this slide I made to kind of just spell out the different steps. So the first thing they do is they package mRNA, and mRNA is basically nucleic acid. It's really just a recipe for the protein that make up the virus. And the reason they pack it in this liquid fat is just so that it can inject and kind of spread around into your body and into the muscle. It's taken up by the muscle. And then, as I mentioned, the cell's normal machinery just doing its business kind of cranks out the protein. And it's basically just like sneaking a little extra recipe into a working kitchen. And so it makes the protein, which then gets put on the outside of the cells, which allows our immune system to see it. Next slide, please. So what do we know from the studies of this vaccine? So the first trials were, of course, done in adults, and these vaccines got the same kind of multi-step process that any other vaccines got, which is they start with very, very small, they start in animals, then they start in very small numbers of humans just to make sure they're safe. Then they do what are called dose finding studies, and that's kind of when you get into phase 2 studies, where you look at what's the right dose, and then and whether it looks like it's safe in a small number and seems to be doing what we think. And then what are called phase 3 trials, where you prove that it gets to your goal. It actually prevents infection in this case. And those are the randomized controlled trial model of a phase 3 study. So the first studies around Pfizer, as everyone knows, that was one of the first to become approved. They included 21,000 adults in each arm, and they demonstrated really striking efficacy at that 94.8%. In the vaccine arm compared to the control arm. So this was far more efficacious than people frankly hoped, realistically, and really impressive response. Next slide, please. So what do we know from the study in 12 to 15-year-olds? So this was part of their original design, was to look at that in 12 to 15-year-olds. But because they showed that the immune response was effective in 20,000 adults, they don't do it again in 20,000 12 to 15-year-olds because we know it works. What they're going to show here is safety is their first goal, and then they look at how well it makes antibodies to show if we can compare it to the adults. So those data are shown here. They use the same dose as in adults, but it was only 1,000 kids in each arm. They got a really nice response, and you can see there the response that the arrows pointing to was the level of antibodies, and that was more than that even in 16 to 25-year-olds. So a really good response. And even though they weren't really supposed to be looking at it because it was a small number, it showed really powerful protection. Basically, no cases of infection in the vaccinated people and some in the placebo. So really impressive data, robust response, looks great, and it's based on these data that it was approved. Next slide, please. So what we hope to be talking to you about tonight would be data from the same trial, similar design, but in 5 to 11-year-olds. But unfortunately, those data have not been released. There was a press release about it on September 20th that suggested they got comparable antibody responses, and it was very similar side effects, but it's just a press release. We really need to see the data, and so does the FDA. They've been submitted. The FDA is going to review them on October 26th. So we're all anxiously awaiting this date. They'll probably release the data a few days before that. So you'll see stuff in the news on the 24th, if not sooner. We can be looking to that. And what's different about this study compared to the adolescents is they're using 10 as opposed to 30 micrograms, so a smaller dose. And that's just because we saw that you can get a really robust response with the 30 and the 16 to 25. So going for smaller, and then about 2,000 in each arm. Next slide. Okay, lessons from the surge is how I wanted to close. So if you want to go here to the next. Okay, so what do we see with the surge? And I think everyone knows, both from the press and from our local experience, that we saw new numbers of cases in kids like we hadn't seen before. This is the weekly infection rates, number of cases added, and you can see the spike exceeded that we saw in the winter. And in fact, because of the protection conferred to adults, the relative portion by children was much greater, and children made up a quarter of the cases on the last week shown here on October 7th. Next slide, please. And we were also unfortunately reminded that children can get very sick from COVID-19. It is one of the great stories of this pandemic that children have are overall at lower risk of severe illness, but they still get sick. There have been 23,000 hospitalizations cumulatively since the beginning of the pandemic. The number of deaths there, of course, are much smaller than seen in adults, but we don't see deaths in kids as much. And this is sobering, and we don't want any kids and adults, deaths in children. And I can also say anecdotally from our experience in the Bay Area here, with this last surge, we had children very, very sick in our ICUs, on ventilators. This includes 2-year-olds, in addition to unvaccinated teenagers that really suffered as a result of this pandemic. So we were reminded in a very real way that we can't consider the end of the surge the end, and we need to be ready to prevent disease in children. Next slide, please. We also learned that and a lot of press about this, about variable efficacy against the Delta variant. And this slide summarizes here a bit what we know about the Pfizer vaccine specifically against Delta. We know that it wasn't quite as good as some of the early studies preventing symptomatic disease and confirmed infection, but still efficacious. And then it was still very protective against hospitalization or death. So it prevents infection on some level, it prevents transmission, and it also prevented hospitalization. In none of those cases is it 100%, but still very powerful. And this is what meant that we didn't see the big bump in adult cases, but we did see them in children. Next slide, please. And we also learned that specifically in adolescents, it was productive. And this was data that published at the end of September. Hospitalizations and ED visits for children were 4 times lower in states with good vaccine coverage across them. And specifically in adolescents, hospitalizations were 10 times higher among the unvaccinated and vaccinated. And like I said, this is very much what we saw in the Bay Area as well. Next slide, please. We also learned that the Delta variant was very efficient in spreading in homes. And I think the take-home from this is, of course, it's not surprising people are living close in home settings and they're going to be giving it to each other. But it was a reminder that we really need to think about vaccinating like a home and vaccinating the places where it's transmitted so that it doesn't leave these places where people are in close contact, such as schools. That basically you're bound to get it from home first and bring it to school, much more likely than get it from school and bring it home. Next slide, please. And finally, these are data from the LA school district when they were just opening fall, and then a ton of cases led to closures of schools. And I think with this slide, I wanted to make a kind of an important distinction, which is the reason the kids missed dates from schools was because cases came in from the outside and were diagnosed, not because of a lot of outbreaks in the schools. And it was just a reminder to me that really to keep our schools open is to keep our community incidence low and to keep everybody protected, children and adults at home, so that we can keep our schools safe and kind of COVID-free through the school year. So I will now pass it over to Tara, who will talk a bit more about the safety.
Thank you so much. This is Dr. Tara Greenhow, and I will be talking about COVID-19 vaccine side effects. Next slide. Similar to Dr. Rule, I have no financial relationships with a pharmaceutical or vaccine manufacturing company related to the content of this presentation and have not been involved with any of the vaccine trials. Next slide. So Dr. Rule already discussed the numerous benefits of COVID-19 vaccination for children. So my goal for the next 10 minutes is to discuss the side effects, putting them really into a perspective, talking about common side effects, and then discussing some of the more rare side effects. Every family must weigh these risks and benefits when making the important decision on whether to vaccinate their children. Next slide. So as Dr. Rule mentioned, unfortunately, at the time of this presentation, we do not have anything but a press release on children 5 to 11 years old and their side effects. And so I will mainly be discussing the known side effects of the Pfizer COVID-19 vaccine studies in 12 to 15-year-olds. And I'll remind everyone in the audience that Pfizer is the only licensed and approved vaccine in children in the United States. Children 12 to 15 years old had similar side effects to those 16 to 25 years old. And via the press release, the side effect profile was the same for 5 to 11-year-olds, similar to other teens and adults. Importantly, the vaccine was safe with mild side effects experienced 1 to 2 days after vaccine. There were no blood clots or severe allergic reactions. They followed children not just for the 1 to 2 days after a vaccination, but actually for the entire month after a vaccination, and found that serious adverse events occurred in less than or equal to 0.4%. But in reviewing those cases, none were considered vaccine related. And importantly, there were no deaths reported. Next slide. So what are the most common side effects to experience when you get the COVID-19 vaccination? The most common is injection site pain, which occurs in over 80% of individuals. Many also experience fever, fatigue, being tired, and having a headache. But these studies also raise the real importance of using a placebo-controlled design. So over 1,000 children received the COVID-19 vaccine, and over 1,000 received an injection of saline in their arm. And importantly, even those that only received saline, 1/4 of those had fatigue and headache after that injection. That would definitely lower your rate of fatigue and headache due to the vaccine itself. The events we're going to discuss in the following slides are really those that are found post-approval. Those rare events are detected through post-rollout surveillance and reporting, and we have a robust surveillance system to detect even exceedingly rare side effects. Next slide. So the first I'll discuss is anaphylaxis. That is a severe allergic reaction. The rate of this is 5 cases per 1 million Pfizer vaccine doses. So to put that in perspective, that is 1 in 200,000 individuals. That is comparable to other vaccines that we commonly use. And in addition, those anaphylactic reactions were more common in individuals that had a history of severe allergies. It is because of this risk that we observe all individuals for 15 minutes after a vaccine. If your child has a history of an immediate allergic reaction to a vaccine or any history of severe allergy, they should be observed for 30 minutes after a vaccine. And if they have a severe allergic response or are already allergic to a known component of the COVID vaccine, they should not receive the Pfizer vaccine. Next slide. Next, we'll talk about myocarditis, which has been in the news quite frequently recently. And this is a very rare COVID-19 vaccine side effect. For non-medical people in the audience, anytime that we add itis to a word, that's really just, we add it to a medical term to mean inflammation. And in this case, the myocardium or the heart muscle is inflamed or irritated. There are often many different causes to cause inflammation. With myocarditis, a viral infection is actually the most common cause of myocarditis. And symptoms include chest pain, shortness of breath, and palpitations, which is your heart beating too hard or fast, skipping a beat, or fluttering. Next slide. So as I mentioned, viral infection is actually the most common cause of myocarditis. And we actually see myocarditis following COVID-19 infection. You are 16 times more likely to have myocarditis if you have COVID-19 than if you are a patient without COVID-19. It's about 150 cases per 100,000 people. So that risk is 1.5 per 1,000 COVID positive individuals. You may have also seen that there have been studies of high intensity athletes. And in some of those studies, they even quote rates as high as 2%. Next slide. MISC is an acronym for multi-system inflammatory syndrome in children. It is a rare but serious condition that follows COVID-19 infection. And as the name implies, it is inflammation that is seen in many organs, and the heart is the most commonly affected organ involved. All children with MISC are admitted to the hospital and need a multitude of different medications. Many of them are critically ill and end up in the ICU. There have been over 5,000 cases through the beginning of October of this year, and there have been 46 children to die. We break it down by age. 6 to 11-year-olds account for 38% of MISC cases, many of whom have long-term sequelae. The risk of MISC is almost 1 per 1,000 COVID positive children. Next slide. Now we'll be discussing COVID-19 vaccines and their risk. So this occurs very rarely. Symptoms develop in the week after the vaccine is given, typically days 2 to 4. It is most common in males and more common after the second dose of vaccine. Multiple studies globally, as well as experience, have shown that the course is mild with a full recovery. In fact, it is often so mild that just ibuprofen will treat this condition, and there have been no deaths. Next slide. So what are the relative risks? So I've discussed that with COVID-19 infection, your risk of myocarditis is 1.5 per 1,000 COVID positive individuals. And a child's risk is 1 per 1,000 COVID positive children. Your risk of myocarditis after COVID-19 vaccination varies by age and dose, but if we focus just on children, the rate is 0.06 cases per 1,000 second doses in males 12 to 17, with a slightly higher risk for those 16 to 17 years of age at 0.07. And females have a much lower risk at 0.004 per 1,000 second doses. Only post-vaccine surveillance will be able to detect this exceedingly rare side effect, and it's unknown if the lower dose will account for any lowering of the myocarditis risk. Next slide. So what are some COVID-19 vaccine myths? It's often very challenging to stay up to date on all of the myths that are being circulated through social media. However, I want to make sure that I address some of the most common that I have seen. It is false that a COVID vaccine causes COVID disease. As Dr. Rule mentioned, we are injected with a fragment of the vaccine. It's not alive. It is false that COVID-19 causes infertility or that it changes your DNA. The mechanism in which it gets in is with the mRNA. It does not actually change your DNA. Next slide. It is also a myth that you could become magnetic due to this vaccine, or for this vaccine to actually insert a microchip into you. And then finally, there was a really poorly performed study that was recently published that claimed that the vaccine may actually cause 150,000 deaths. That has been discounted, and it is not to be relied upon. Next slide. I just want to really finish with a huge bit of gratitude and thank you to our Marin community. It's with a lot of pride that I live in Marin County. We are the most vaccinated county in the state, at 97.3% of our eligible population receiving at least one dose. And I'll just remind everyone that increased vaccination of children and adults really slows the spread and decreases the burden of COVID-19 on our vulnerable communities and populations. And it's really with this that I will now turn it over to Dr. Willis. Thank you. Next slide.
Thank you, Dr. Greenhow and Dr. Well. I'm highly reassured to be surrounded by such experts. It's sort of how we've been traveling through this pandemic response all the way along on all sides, partnerships, and also want to thank you, Mary Jane, and the MCOE team for working with us to really ensure that our schools can be as safe as they have been. It's hard to know how to talk about success in the context of a pandemic, because at best we are mitigating harm. But I think it's clear when we look at what's happening across the nation and across the state and even the region, we are in a bubble of relative goodness, and there is privilege there. And I think there's a lot of reasons for that, but one of the most important is the way we've come together across the healthcare community, public health, and schools, especially for our youth. Next slide, please. So here's our current status regarding our vaccination rates. We have 92% of Marin residents age 12 and over are fully vaccinated. As Dr. Greenhow said, that's the highest rates in the state. I'll update your slide. It's now 98% to received at least one dose.
Impressive.
And 80% of our residents are fully vaccinated. But if we're building a wall against this virus that is threatening the health of our community, there's some important bricks that are still not laid. And that's our 33,000 residents who are under age 12 who are not eligible for vaccination because they have not been authorized. We are anticipating authorization to offer vaccine to our 20,000 Marin County residents who are 5 to 11 years old by the end of this month. And as Dr. Well indicated, there will be meetings with the CDC or FDA on the 26th of October. So I want to signal that we are planning our vaccine rollout. I'll share some of the details in a bit. But all of that is contingent on what the final decisions at the federal level will be. Next slide, please. So here's our goal. We have set goals all the way along, and our goal for this remaining unvaccinated cohort is that 75% of Marin County residents aged 5 to 11 will be protected with at least one dose of vaccine within 1 month of authorization. If we get that authorization at the end of October, then we would be looking at in the month of November, basically, to vaccinate 15,000 out of our 20,000 residents aged 5 to 11. And we have plans and operations in place to vaccinate that many. Next slide, please. We were successful. We had set a goal when our 12 to 17-year-olds came online to vaccinate at least half within the first week, and we achieved that goal. So we're fortunate to have partners that are able to move efficiently and quickly. So these are some of the knowns. I just wanted to sort of establish these as sort of the pillars of our fundamental understanding of the benefits of vaccine amidst all the misinformation and other noise. First is that unvaccinated people are at higher risk for infection. I'm really just reiterating what's already been said, but I want to say it again, right? The next is that risk for infection is even higher when unvaccinated people are gathered together, because there's a higher risk that they, being individually at higher risk of being infected, are also transmitting it to others in that environment. School environments categorically are at higher risk for this reason, despite all of the great work we've done to mitigate risk in our schools. And then finally, when unvaccinated people are infected, they are at higher risk for one, infecting others, and they are also at higher risk of serious illness and hospitalization and death. So these are really the key elements that lead to our prioritization of vaccinating and offering the protection of vaccine to every community member who is eligible. Next slide, please. You may be familiar with this. This is our dashboard of how we're doing in our schools with regards to COVID-19. This is updated weekly and shows that 100% of our schools are fully open every day to classroom-based learning. This is a milestone we achieved before the end of last year, and we're among the first counties in the state to achieve that milestone. What this shows is that we have about 1.5 million now total accumulated student days just this year, starting in August when schools started to reopen after the summer break. 84% of our students who are eligible are vaccinated. That's our 12 to 17-year-olds. What's important, though, if we look at our entire student population, is well less than 50% who are vaccinated, because all students under age 12 have been unable to be vaccinated. And then on the right, you see cumulative COVID-19 positive students, 180. Dr. Worrell mentioned and highlighted what happened in Los Angeles, that those cases among students in school are primarily acquired. The infection is acquired outside of the school setting. And if you look there, the total suspected in-school transmission is 17. So what we see at 180 COVID positive students and 20 COVID positive staff, only 17 of those cases were actually acquired in the school setting, which is an important argument for vaccinations, because what we know is really we can control, and we've learned very well that we actually have the ability to control the exposure experience in the school setting through our protocols and the excellence that our schools have applied. We have much less control over that risk experience outside of the school setting in households. And those are the things that many of us value most for our kids. I've got an 11-year-old who's eager to play with his friends, wants to go to birthday parties, wants to play soccer, wants to be out. That's where his risk is actually highest. And I know, by the way, vaccinating him, he'll be able to engage in those activities more safely. Next slide, please. This just reminds us, to Dr. Worrell's point, that we really need to think about the behavior of the Delta variant to determine what our risk experience is as a community, because it's all Delta all the time right now in Marin. We have the last 6 weeks. We're vigilantly sampling multiple samples for sequencing. And we've only seen Delta over the past 6 weeks in Marin County. Next slide, please. This was an outbreak that was really kind of a wake-up call for us that was published as a Marin County outbreak that was published by the CDC and had a lot of national attention and really helped influence some of the policies around mandatory vaccination for staff and also offers us a sign of our vulnerability. This was an outbreak of an unvaccinated teacher who infected in a classroom 12 of 24 students. And then of those 12 students, 5 infected others in their household. So they actually brought the infection home and infected others. And there's obviously a risk in this setting if there had been a grandparent or someone else who was at risk for a more serious outcome, we could have seen more serious morbidity, hospitalization, or death out of this. Fortunately, that did not occur in this setting, but it does again highlight our vulnerability, especially with regards to the Delta variant. Next slide, please. So vaccination protects each child individually, and importantly, as well as their classmates, friends, and family. Next slide, please. So I want to talk about what we've learned about the benefits of high vaccination rates in Marin. Next slide. We are in many ways in a good position to demonstrate to the nation what it means to actually achieve high vaccination rates as the most highly vaccinated county in the state. What this slide shows is the relationship between vaccination rates and case rates. On one axis there, on the horizontal axis, what you see is vaccination rates. And you can see that Marin there has the highest vaccination rates at this time among everybody fully vaccinated, is about 83%. And then on the vertical axis there, you see the number of cases per 100,000 residents. What you can see is that we have the highest vaccination rates and the lowest case rates. And the red circles there are counties in the Bay Area. So this highlights the fact that we are really fortunate to be in a region that shares that characteristic of high vaccination rates and low case rates. And then on the left side, you see that those are counties that have much lower vaccination rates. And in fact, they also have very high case rates. Every single county with a vaccination rate under 50% has a case rate over 25 per 100,000. So that's how if you're unconvinced about the data in terms of the individual benefits, looking at this population associations between vaccination rates and case rates, I think is very compelling. Next slide, please. And this again just is another way of showing that this is our case rates per 100,000 residents compared to Marin, California, and the United States. Next slide, please. And most importantly, what we are most concerned about, obviously, is the most serious outcomes, including death. And our death rates per 100,000 residents since June in Marin are about 1/10 of what they are in the state of California and about 1/30 of what they are in the nation. And this is, again, due primarily to vaccination. Yes, our adherence to some of the other measures like mask wearing is a vital contributor to that. But by far, the most important factor here is our vaccination rates. Next slide, please. Also, just in terms of decision-making, it's important to recognize that there are policies tied to vaccine status, and our freedoms will be determined in some part by whether or not we've been vaccinated. Just to go through some of those specifically, unvaccinated people who are close contacts to a case must quarantine. When someone is vaccinated and they are close contact to someone who's infected, they need not quarantine. They just monitor for symptoms. So that's one of the benefits of vaccine. It's important in schools. So children who are unvaccinated are at higher risk for spending more days out of school if there's exposures in the school setting, because they will be needing to quarantine. For testing, unvaccinated students are in higher risk activities like sports, will need to test weekly. If they're vaccinated, they don't. An indoor number of indoor events, increasing number will require vaccination to attend. Unvaccinated travelers, in many cases, are prevented from entering countries. Most countries now have a requirement to be vaccinated to enter. And returners who are unvaccinated are often asked to quarantine before they engage in the community. Vaccine verification is required in a growing number of settings, and likely requirement, as you've seen from Governor Newsom, for school attendance by the next school year. Next slide, please. So where we'll be able to get vaccinated once it's authorized. Next slide. And I'm not going to go through all of these locations. These will be visible at getvaccinatedmarin.org. That is our website, and also the Marin County Office of Education and Communications that will be going out to all parents through the schools. Once we get closer, again, these are provisional dates because we're not exactly sure when this will be authorized. And these can be shifted back. If we don't get the authorization until early November, we can shift all of these operations into the following week or 2 weeks. Next slide, please. So these are weekday, those are weekend sites in schools. We also have weekday sites in schools. In total, we have 32 school-based vaccine clinics organized between the end of October and mid-December in all parts of Marin, West Marin, Southern Marin, Central Marin, and Northern Marin in schools to make sure that everyone has access to the vaccine. Next slide, please. And then there's additional pediatric vaccination clinics, and including, beyond those with healthcare providers, there's a site at the Northgate Mall, partnership with Marin County Public Health and Safeway. You can walk in, and then our mobile vaccination sites. We have teams that go out every day across the county, and they will also be offering vaccines for our children. And then on top of that are pharmacies that will be offering vaccines, as well as your regular healthcare provider, like Kaiser will be offering vaccines. So there will be ample opportunities to get vaccinated. Next slide, please. I just want to end with this. So this is, history. There's some history here. KO Polio Day, September 23rd, 1962. Polio at that time was a major contributor to infantile paralysis. And if you'd seen the pictures of, iron lungs, hundreds of children who had been rendered paralyzed by this virus, the vaccine came along. And with a massive campaign to vaccinate our children, we were able to vaccinate, next slide, please, over 100,000 of our residents in one day. There's pictures from Marin County, people lined up to be vaccinated. It was a sugar cube handed out there on the left side, Marin City. Down on the right is Davidson Middle School, which is one of the sites we'll be at for our vaccinations. And has anyone seen any polio in the last, polio has basically, we haven't had any cases of polio in Marin County in decades. Thanks to the protection of the vaccine. Next slide, please. And these are just some images from that. I thought this was great that the archives at the Civic Center have these photographs. Yeah. I can imagine, years from now, people will be looking at pictures of our vaccines that we'll be offering. Next slide, please. And this is how the health officer at that time summarized it. Unprecedented demonstration of what can be accomplished when the efforts of an entire community are joined in a common purpose for public health. And here we are again. Next slide, please. Thank you. And that's my 11-year-old who can't get vaccinated yet at the Rosie the Riveting Museum, and I'm eager to get him protected as soon as we can.
Great. Okay, wonderful. So thank you all so much. So what we'll do is Ken Lippy is going to be able to help us begin to address those 97 questions. So do you see those there that we're not able to see the questions? So Ken, that will be great. I'm going to start with a few questions. And I'm not sure one of you can sort of take these. There's a couple of questions related to the flu vaccine, and how do you feel about giving the flu shot along with the COVID shot? Who would like to answer that?
I'm happy to take it. So the American Academy of Pediatrics met, and they felt that it was completely safe and effective to give 2 shots at the same time, whether that's flu and COVID or that's another shot that the child needs. The importance is actually preventing or giving both vaccines so that the child can be protected. And so we are anticipating a significant flu year. We did not see a lot of flu last year. And because of that, we do not have continued immunity. And so a vaccine is even more important now than ever.
There's a question here related to at what point do you think that the actual vaccinations will be required for students to actually attend school?
Well, the governor has signaled that that's the direction the state is moving. It's, I think that it's pending the full approval of the vaccine rather than the authorization. As what we're talking about here is the emergency use authorization, which are the terms under which all the vaccines initially rolled out. Pfizer for adults is now approved. That timing will really depend on the accumulation of data after it's rolled out into the public to determine whether or not we're able to offer that full approval by January 1. They did signal that January 1 could be the earliest that would occur. I don't think that we're going to reach that point, especially if it's not, if there's any delay in the rollout under an authorization. So it's most likely to occur at the beginning of next year. Importantly, there are many diseases that we require children to be vaccinated against. Vaccine preventable diseases, serious diseases, measles, mumps, rubella, polio is one of them. And those are already on the list. So what we're really talking about is just adding COVID-19 to a list of diseases we already know are preventable through vaccine that children are required to be vaccinated against in order to attend school in California.
So this is a question that's describing that one of this family's children is a small 5-year-old, 20th percentile weight. And there's a question about whether or not the dose would be different for a child that's appropriate age, 5 to 11, but very slight in terms of their weight.
I think we'll have to see what the exact kind of authorization provides. And I mean, when they provide that authorization, they base it on the data that was in the study and the size and the children in the study. Now, I would anticipate that someone that is at the 20th percentile is well enough in the norm that would be covered by the authorization for that age group. But I do want to add to that comment to answer some other questions that I saw in there about kind of dosing, because I think it can be hard to understand why a dose can be 1/3 and then they turn 12 and then it's supposed to be 3 times as much. I mean, I think we are trying to make our decisions. I say we. I mean, the FDA tries to make its decisions based on the strongest evidence we have from the trials, and that's when you're giving the dose to the people in that trial and you match it. Do I think a 12-year-old that is just underweight and could be an 11-year-old might then fine with a 3rd dose? Probably, but we know what those people did in the trial, and those are the data about safety and everything we know. And likewise, for the younger group, we know it. So there's nothing magic that happens on the 11th to 12th birthday or at the 5th birthday, but we just have to have confidence that that's what we're making it the best, strongest data what we have when we look at those points. And it's also different with vaccines and with drugs. I mean, with drugs, you think of something, it's like a concentration in the blood and this kind of stuff. But here it's really, we're generating an immune response to amount of this protein. So it's not going to be as super dose sensitive that, a percentile differences in weight would make such a big difference in response. That's how I think people need to try to frame this. I don't know, Tara, if you have anything to add to that.
I agree. I definitely agree. And I think that, they look at the immune response, and that is more that changes with age. And so, as you said, a slightly smaller person may still have this, have the same immune response as another child their age. So unlike how we dose antibiotics, this is different. And so I say, let's rely on what has been studied, because then we can speak to the safety and the efficacy of it versus going with things that haven't been studied before.
Well, this is sort of a practical question, but we were talking as a team this morning, and the question came up that there are times when if it's this small child that you might be giving the shot in the leg as opposed to the arm. And so does that sound accurate?
So I don't know what I think. I imagine for the studies in younger infants that they're looking in a different location. The logic around that is because you just want to get it into a muscle, and like babies have small muscles in their arms, they got big ones in their legs. That's the logic of that. But I don't know. I don't think for the 5 to 11.
I haven't heard of that outside of your sort of immediate year of life. That becomes more of an issue for infant vaccines. Again, when the shoulder muscle is really small. But after that, the importance is that it has to go into the space that the vaccine was designed to. And so if it goes into the muscle, if you give it into a child with a larger thigh, it may not actually get into the muscle. So that's why it's important to, again, give it where it's designed to go, which would be in the older children, that's all in the shoulder.
Okay, very good. Okay, Ken Lippy, if you could help us from here.
Sure. There are a number of questions based on, or asking about the need based on some of the data that was presented. I'll read a couple and then I'm sure the answers would cover them all. But whooping cough, measles, and mumps vaccines are decades old and proven to be effective against diseases that are very deadly to children. Since COVID is not deadly to children in any significant way whatsoever, why would I give my child a vaccine created a year ago? And then a follow-up similar to many others, given that we've been in school for a year now with very low positive rates and very low transmission rates, what is the purpose of a vaccine mandate?
Do I take the first part? I can take the second part.
Sure, I can speak to the first. I think it's hard for me when I see when I've been taking care of children in ICUs for people to say it doesn't hurt kids. I appreciate that it hurts far fewer kids than adults, but this does cause disease in kids that's very significant and causes deaths in kids that's very significant. We're lucky in the US that we have great medical care systems and our ICUs haven't been overloaded, so we can take care of kids on ventilators. But this is not benign just to a good number of children. And it's not benign. And some people often ask, well, my kid doesn't have any comorbidities and should do okay. Well, that's true, but then the kid next to them in the class might. And so I feel like it's really, it's about those two things for me. I also just wanted to make one comment because I'm trying to hit some of the questions that I saw that kind of came up there about this too. The people worried about, that we know a lot more about these vaccines that have been around for a long time, and this one's new. I mean, I made the point it's been under development for a while, but it's also that we haven't seen long-term side effects beyond the first few weeks to months from any vaccine ever. And again, to underscore, that kind of makes sense, right? I mean, a vaccine, you're giving a little flush of this protein and then it goes away. Whereas if you get COVID, you get this replicating in your body and it goes on for a long time. And people we know have long-term side effects from COVID. They get long-term kind of sequelae from the infections, from the symptoms. And even though it's, again, smaller in kids, some kids get long COVID. I've taken care of many kids that have symptoms for 6 to 12 months after prolonged fatigue. And so this idea that to worry about long-term effects from a vaccine, I think is really misplaced. I think we should be worrying more about long-term effects from kids getting COVID.
Yeah, to the question of what's the value of a mandate, as I understand the question, if schools are not the main location for transmission. Well, it is true that the risk is higher in the community, and I think that's a strong argument for vaccination, because again, you're less able to control the risk experience. We also know that our schools remain vulnerable as settings, and the outbreak that we saw in Nevada is a strong sign of that. The schools are working really hard every day to prevent transmission. Children are covering their faces in classrooms every day, all day, to prevent transmission. This is not our vision of schools forever. We want to restore normalcy and in a safe way. Schools, we're fortunate that classes are not closing, but across the nation, we're seeing schools close and classrooms close at alarming rates based on transmission. Vaccination is going to be a critical element for us to restore normalcy in the school setting and make sure that we're not closing schools based on preventable transmission.
Ken?
Next question is, I noticed the tentative schedule plan for the Marin super pods, that some of the second doses are 3 weeks apart and others are 4 weeks. Is it okay to wait 3 or 4 weeks? And do we anticipate a booster being needed?
So the vaccine is given 3 weeks apart. However, if it's 4 weeks, it still works just as effectively. Or although we prefer you to get that second dose on time, 3 to 4 weeks. If you miss the appointment and you come in a couple weeks later, that is also fine. The efficacy, meaning how well the vaccine works, is still the same, and you're still protected a couple of weeks after that second dose. We are waiting on additional data to be shared, and for our colleagues at CDC to look over data on the need for boosters in children. Right now, boosters are not licensed or approved in any children. They're only approved in people 18 and up. The difference between that and a third dose is that there are a group of children who are immune compromised, meaning they do not make as good of an immune response to the immunization. Those children are eligible for a third dose 1 month after the second dose. And that's really to just try to get their response to the vaccine up higher so that they can have an adequate response to the vaccine itself.
We may have touched on this, but there are so many questions like it. I think it's worth just making sure we get a good answer and everybody understands that if my child is turning 12 in January, do I wait and get him the adult dose? Or if it's available in October or November, should I proceed and get the dose then?
So you get the dose when you get it available. It has been studied in 11-year-olds, and so if and when we get that approval and their immune response is shown to be just as great, then there were children who were 11 years old, same as your child, who are several months before or a few months before they turn 12, and you can rely on the studies and then the data that is then reviewed to show that, based on your child's current age, that they're safe to get that 10 microgram dose.
Okay. Ken, we're going to have each of our panelists give some closing comments that they might want to. So if you could go to the next question or group of questions that you think is the most important.
Well, the last group is all about timing and wondering how long between the day the FDA approves the vaccine and when it can be distributed and made available in the community.
Yeah, I can address that. So typically, things move relatively quickly. Once the federal authorization has been offered, things tend to move quickly. So for us in California, there's the FDA that meets, right, and then the CDC, and then Dr. Walensky offers the CDC's recommendation for authorization. And then that goes, and for us, that goes to the Western States Scientific Review Group, which is actually Oregon, Washington, and California. They have a separate process where they independently review the data. In the past, it's always just corroborated what had already been established federally, but that's another layer. They usually set their meeting to meet just as soon as the CDC authorization comes. It doesn't introduce any delay. It could be a nighttime meeting even if necessary. And then California Public Health receives their recommendation and offers the final authorization for us. That can happen over a series, really just 24 to 48 hours. So we would expect, in this case, I think the FDA is meeting on the 26th. Mm-hmm. We're hearing now that the CDC may actually be waiting until the 2nd of November to meet, which would be unfortunate. And again, this is all real time. But once the CDC meets, they'll make their recommendation, and then we would expect to have the vaccine available 2 days later, no later than that, in Marin. And again, we are idling in the driveway. We are ready to go as soon as we get the authorization.
Great, thank you. So, Dr. Rill, would you like to start with closing comments?
Yeah, I guess I just wanted to say that, to acknowledge that, this was a very pro-vaccine panel. And by that, I think I don't want to trivialize this discussion about vaccines. Vaccines are something we're putting into our kids. I have a 9-year-old and a 12-year-old. Every time we do anything, we worry about what it's going to do. And this has gone fast compared to what anybody else has experienced around vaccine development in their lives. And I think it's important for us to just kind of acknowledge that. I don't want to simplify this and say that this should be easy for everyone, that you shouldn't do this without thinking. It's just to acknowledge also that this has been a time of a lot of unknowns, and every single month has been a new twist and a new scary thing for us to endure. And I think we have to, at each step, we have to make our best steps based on what we know and the strongest information we get, which we have to be careful about how we consume and where we hear things and what we look. And, Tara and I review this data, Dr. Welch reviews this data, Mary Jane, we're reviewing these data and making best advice based on the strongest information and based on the people that have their eyes over the biggest pool, like the FDA and the CDC, and information really about the numbers on a large scale. So I think, it's scary, but I think each step we have to make it based on our strongest information. And And we're going to continue to monitor these vaccines. I mean, it's not over. The first stage of these studies, we make our best decision based on those, and they continue to get monitored. So this is not a simple situation. This is one that we're all, moving forward with the strongest information possible to really kind of combat the pandemic and all of its problems on all of our population, I guess.
Harper.
Go ahead.
Yeah, thank you. I think that as a parent and as a pediatric infectious disease specialist, we always want to do what is right by our children. We want to do what's right by our patients. And I think that there's a lot of scary information that is out there on the internet. There's a lot of misinformation and disinformation, which is purposefully having incorrect information. And I hope that if there are people in the audience that are continuing to have questions, that is normal, that is right. We all try to do our best. Reach out to a trusted source, your pediatrician or another medical person, to get to the bottom of what might be out there, because there is so much information, especially on social media, that it's really hard to know who to believe. And because a lot of that information is sent from family members that we love and trust, we feel like it is actually correct. When in actuality, where they're coming up with some of this false information is it's sort of mind blowing. And I really think that it's amazing that we have a community that is pro-vaccine, but for each of those, there are people that we still need to spread the word about safety and about misinformation that's out there.
Yeah, thank you. I mean, I look back and I see 98% of our residents have had at least one dose of the vaccine. So what I do see is a community that has a shared experience and a shared understanding of the benefit of the vaccine. And my assumption is we're going to apply that to the next phase. And we will need to maintain that level of protection. One of the things that's both inspiring, but also I think challenging about vaccines is that they're prevention, right? And it's hard to know when something is prevented, because by definition, it is something that did not happen. And so what we are doing is actually, a series of non-events, essentially. What we're seeing is people who did not come into the hospital, schools that did not close, outbreaks that did not occur in long-term care facilities, businesses that did not close. That's the result of high vaccination rates. So that's what we earn, and we have earned this, and that's I think an important where this is earned through our following the science and stepping forward and taking the steps we need to take together to protect ourselves individually and as a community. And I just think we need to look around to each other if we want to have any gratitude for the position we're in now with low case counts, the first county in the state to come into the yellow tier, low mortality rates, all the things we're seeing. Schools are remaining open. Really looking around to each other and recognizing the gratitude is shared, which I find really inspiring. So thank you.
And maybe I would just add that, just as a reminder, as our school staffs were moving through this vaccination, everyone did not jump on board right at the start, right? In the very beginning, we were looking at rates around 40%, right? And then, today we're reporting to over 95% of all the school staffs are fully vaccinated. So people have a different rate for themselves. And obviously, as families, you'll make the best decision you can make for your kids. The great news is that we're ready, because some people in our community are ready. They're ready right now to have their students vaccinated in that 5 to 11 range, and we're ready to be able to accommodate that. But we will continue to make sure that we're providing the opportunities over a period of time. So to Dr. Ruel, to Dr. Willis, Dr. Greenhow, thank you so much for being here. We really appreciate it. Anything else? Matt?
No,
We're
thank
good?
you guys so
All right,
much.
thanks,
Thank you.
everybody. We appreciate it. And we will get to the questions we didn't get to. So please, reminder, if you are able to join next week, you'll be able to hear a presentation with other doctors who are Spanish speaking, in addition to translations in English. Also, we're going to put a quick note in the chat. We are looking for volunteers for our vaccination pods. And so if anyone is able or willing, we would appreciate it very much. So thank you.
Thank you.
Thank you.